Hello everyone, I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and a faculty of orthopedics for PG aspirants as well as the postgraduate residents. The video that you are going to watch today is from a topic which is considered to be the most quintessential topic in orthopedics, particularly for all undergraduates who all are in their pre-final or final year. When we talk about orthopedics, we literally take it as equivalent to fractures. So today I will be topping that very, very basic aspect of this topic of fracture. Not only we will be talking about what is a fracture, but we will also be talking about what are the types of fracture, what are the different classifications, what are the different fracture patterns, and how do we diagnose them, and what are the associated concepts, and how do we manage them. This video, this lecture will give you a concept, it will give you MCQs, but most of all, it will give you a common sense about my topic, about my subject, that is orthopedics. It is highly recommended for all those who are entering just into the pre-final and final year MBBS, because this is going to give you the foundation for the subject called orthopedics. So what are we waiting for? Let's begin. First of all, we have to understand what is a fracture. See, it's very simple. Any break or any breach in the continuity of bone is what is called as a fracture. That's a structural continuity which is broken, which is breached. So that constitutes something which is called as a fracture. Now you can classify fracture into two types. One is a closed fracture, another is an open fracture. There are different classifications of a fracture. One of them I'm sharing here. So one is a closed fracture, or also what is called as a simple fracture. So you can call it a closed fracture, or you can call it a simple fracture. Or on the other hand, you can call it a open fracture or call it a compound fracture, but that entirely depends upon what? See, this entirely depends upon whether the overlying skin coverage is intact or not. If the overlying skin coverage is intact, we'll call it a closed fracture or a simple fracture, which is usually there in majority of the cases. But if there is a fracture with an overlying skin which is breached, or there is a defect, or there is a wound, then definitely we call it a open fracture. The word compound was used previously. We don't use the word compound as of now. We prefer the word open fracture for those which are exposed, and closed for which we have the intact skin. In terms of incidence, definitely closed fractures are more common. Let's talk about the causes of fracture. There are different causes, out of which the first cause, the most common cause, is a direct trauma. That's a direct blow. Two people are fighting. One has a stick. He wants to hit the other guy with the stick. He blows the stick on the other guy. There's a direct assault. There's a direct trauma. There's a direct blow. The second thing is, a guy fell down from a bike. He was about to get up, but there was a high speeding car which could not notice that boy properly, and it got run over it. So this is more of a crushing injury. There's a third injury. You're playing lawn tennis or you're playing badminton, and they are going to pick a shot. You go out of your range of kind of movement and you try to pick that shot, and while picking that shot you sustain a sudden adduction plus inversion twisting injury to your foot. So that can also lead to a fracture. And then of course you are doing a lot of weightlifting and you are done with that, and now you're going to put the weight down, and the moment you're putting that weight down, your triceps goes into violent contraction, and your own body's muscle, your own bone is fractured because of that. So in totality, there are four kind of traumas that can happen. One is a direct blow, one is a crushing injury, one is a twisting movement, and one is a extreme muscular contraction. Now, as I said initially, that there are two types of fracture. One is a closed one. That is what I mentioned regarding the overlying skin and coverage. So if that is intact, we call it a closed. If that's not, we call it a open fracture. Now we have one more thing here, that there is one more classification that is based upon whether the fracture line is involving both the cortices or not. On every view, on AP, lateral, you will be able to see two cortices of the bone. So whether the fracture line is through the entire cross section of the bone or not. So if it is through the entire cross section of the bone, definitely we call it a complete fracture, which of course is something that we see more common in our clinical practice. The one in which only one part of the cross section is breached, that is what we call as incomplete fracture. So two classifications broadly we have discussed till now: closed, open, complete, incomplete. Now what I'm going to do is we have already spoken about it. All right, so there is one classification, complete, incomplete. There is one classification, that is closed fracture, and there is a open fracture, which at one point of time was called compound fracture, but not now. So these are the two patterns of classification. There is a third pattern of classification here as well, that is depending upon the anatomical placement of the fracture. Now, did I already tell you about what is a incomplete injury and what is a complete injury? Yes, we've already spoken about it. The one which involves the entire cross section is complete, a part of the cross section is incomplete. Now, in this incomplete injury, I repeat my word, the classical pattern in this incomplete injury, the classical pattern that you always see is basically a green stick fracture. In complete fractures, you can see a spiral fracture. You can see, I'll show you the X-rays also, don't worry, you can see a spiral fracture. You can also see a transverse fracture. You can also see a chura. That means there are more than two fragments and the intervening fragments are very small. So you call it a comminuted fracture. As I said, when the fractured fragment exposes the overlying skin, muscle, tissue, fascia, we call it a open fracture or a compound fracture, better known as open fracture. And the last pattern that we have here is compression fracture. I'll show you the X-ray also, compression fracture. So these are different patterns depending upon the anatomical placement of the fracture. Are you getting me? So till now what we have done is we have understood that break or breach in the continuity of a bone is called fracture. Three sort of classifications. Number one, complete, incomplete, depending upon whether the entire cross section is involved or not. Closed or open, depending upon what is the condition of the overlying skin and soft tissue. And the third classification was basically anatomical placement, in which we have discussed what is transverse. I'll show you the X-rays also. What is transverse, what is spiral, what is comminuted, what is compression, what is green stick. We have seen almost most of them. Now let's take a classical example of a green stick fracture. Let's take a classical example of a green stick fracture. Now guys, when we talk about green stick fracture, there is one thing that I want you to understand, that where does this word green stick comes from. I mean, you were a small kid, you went to a park, your parents were with you, you were just playing around, you picked up a green stick, you picked up something which is probably the twig of a plant, and you were playing with almost for next half an hour, 1 hour. Picnic is over, your parents are calling you, you have to go back home. Your father says, wash your hands and throw this green stick or this plant twig or this whatever it is, throw it away. I'm like, no dad, I want to carry it back home with me. This is my sword, I want to play with it. Your father says, no beta, you can't do this, you have to throw it here. Then you're like, okay fine, if I can't play with this, nobody else should play with this. I will just break it into many pieces and I will hide it somewhere and I will throw it somewhere so that nobody plays with it. Now you're trying your level best to break it. The interesting part is that you can bend it into any direction, but you can't completely break it into two parts. That is impossible. This is how a classical property of a pediatric skeleton is. The pediatric skeleton has huge potential for elastic and plastic deformation. Are you able to understand my point? The pediatric skeleton has huge potential for elastic and plastic deformation. Such a kind of a huge potential that you can try your level best to bend it into all possible direction, but you can't completely break it into two parts. So that is why the word is called green stick fracture. It is by far very clear that this is the most common fracture seen in children overall as a whole. It is by far very clear that this fracture pattern is an incomplete fracture pattern because we are discussing that only. Remember, we had a classification: closed, open, complete, incomplete. First of all, I'm talking about this incomplete fracture. We all know that unicortical fracture, one cortex is involved. So you will appreciate break in one cortex. You can appreciate break in one cortex, but in the other cortex you will appreciate just a bend. You will always have a tendency to see this in forearm bones, radius and ulna, and I would like to make this very clear to all my students here that radius is more commonly involved as compared to ulna. So this, what is in front of you is right now, is an incomplete fracture, unicortical fracture, most common fracture seen in children and usually seen in forearm bones, radius more than ulna, and particularly you will notice, my dear friends, that this is usually seen in the shaft area, usually seen in the diaphyseal area. So I think you must have got a hint about an incomplete fracture or a green stick fracture, a classical one. Now after this, we have to talk about what? We have to talk about complete fracture, because I told you there's a classification, incomplete, complete. So incomplete is over. Now complete, incomplete. Did I tell you about transverse? Did I tell you about spiral? Did I tell you about segmental? Did I tell you about comminuted? Did I tell you about compression? Of course, I told you about all those things. Now it is the time for us to see the X-ray and try to understand the pattern. Transverse fracture. Do you look at the anatomy of the fracture line? Transverse. Do you look at the anatomy of the fracture line? Transverse. Do you look at the anatomy of the fracture line? Transverse. All these fractures lines are clear-cut transverse here. So these are the transverse fracture lines that you are able to appreciate, usually sustained whenever there is a direct blow. After transverse fracture line, the next one that we have here is what is called as a spiral fracture. After transverse line, fracture line, we have here what is called as a spiral fracture. Now spiral fracture is something where you will see a fracture line which is going up in a spiral pattern, as you can see here. You can see the fracture line, alright, so you can very well see the fracture line which is going up in a very spiral pattern. I'm sure it is quite visible to you. So after transverse and spiral, my dear friends, I want you to see a comminuted fracture pattern. I want all you to see a typical comminuted fracture pattern. Now when I say comminuted fracture pattern, that means there are more than two fragments. But the interesting part is that the size of the intermediary fragment should be very, very small as compared to the proximal and the distal fragment. I'll give you an example. There is one, I'll give you an example, you will get a proper understanding of this. There is one fracture pattern here. This is one fracture pattern. This is another fracture pattern here. Now I see a lot of students getting confused here. I'll make it simple for you. This is what is called as segmental fracture pattern, while this is what is called as comminuted fracture pattern. When the size of the intermediary fragment is almost at par with the size of the proximal and distal fragment, we call it segmental. But when the size of the intermediary fragment is quite small as compared to the size of the proximal and distal fragment, we call it a comminuted fracture. Both fractures, whether segmental or comminuted, will have more than two fragments, but it depends upon the size of the intermediary fragment that you can call a fracture to be comminuted or segmental. Please try to understand. Moving further, transverse is done, spiral is done, comminuted is done. The next pattern is another sort of a classification that I've already told you, that we have a closed fracture and we have an open fracture. We have discussed about this classification, so you can very well see an open fracture, and as I have already told you that this word compound is no longer used now because there is no concept of the word compounding now. So you can very well see how the fracture has come to the external surface of the skin in front of the entire word, breaking the entire layers of skin and muscle and tissue and fascia and everything, and fracture is communicating with the external environment. So that is what is called as an open fracture. Now compression fracture. Compression basically means that the bone is getting compressed, and one of the common causes for a compression fracture is, already we are aware of it, this is osteoporosis. A very, very common cause is osteoporosis. It leads to compression of the vertebral body, and that is basically something which will result into collapse of the vertebral body height. You can see the two vertebral body heights here, and now if you can see the vertebral body height, probably you will understand what I'm trying to tell you. This compression fracture is actually resulting into a very classical kind of a spine, that is what is called as fish mouth spine, also called as cod fish spine, also called as biconcave vertebra. Also called as biconcave vertebra. So you have three terms mentioned here, and this is basically what do you mean by a biconcave vertebra. You can very well see that this is a biconcave vertebra. Okay, I'll show it to you again. See, this is the normal vertebral body, and now you have a biconcave vertebra. So you can see the vertebral body column height here, and you can see the collapsed vertebral body height here. So one of the classical causes of this fish mouth spine is osteoporosis. As I've already told you, that it leads to a kind of a compression fracture. Now, kind of a quiz, maybe you can say, kind of a questionnaire, you can say. We've already understood what is a fracture. We've already understood that there is one hell of a classification called as closed and open fracture, complete and incomplete fracture. We've seen what is an incomplete green stick looks like, what is a complete and transverse and spiral and comminuted and segmental and compression and everything looks like. We've already spoken about all those things. Now, can you identify these fracture patterns? First of all, can you identify this fracture pattern here? It is very simple. This is a transverse fracture pattern. Can you identify this fracture pattern? Don't call it comminuted. Don't call it comminuted. The size of the intermediary fragment is quite good. So this is a segmental kind of a fracture. Can you see this kind of a fracture? So this is a spiral cum oblique kind of a fracture. Are we able to understand this? So these are the three different patterns. Now, it's not that these are the only patterns. Are you able to understand my point? It's not that these are the only patterns. There are other patterns also. It's not that these are the only patterns. We have certain other patterns also. Like out of those other patterns, we have an avulsion fracture. Now, avulsion fracture, I'll give you an example. You'll be able to understand what I'm trying to tell you. You're going for a walk. It's quite pitch dark. It's almost 9:30 and it's pitch dark. There's a pothole. You don't see that pothole. Your foot goes into that pothole. Your foot goes into adduction plus inversion. The peroneus brevis, which is inserted onto the tuberosity of the base of the fifth metatarsal, that gets avulsed from there. So technically, your own body's muscle contracted, or a tendon contracted, and it fractured your own bone. So that is what is called as an avulsion fracture. Fracture is somewhere different. I mean, fracture is somewhere else, and the muscular contraction is somewhere else. That is what is called as an avulsion fracture. Don't worry, I'll show you an example. You want to see the example first? I can show you the example first. I can show you the classical example of a avulsion fracture of the calcaneum due to a powerful contraction of this beautiful tendon called tendoachilles. So this is, everybody knows, here we have the shadow of something which is called as tendoachilles. Now tendoachilles is formed out of gastrocnemius and soleus. We all are aware of it. It goes and gets inserted onto the posterior tuberosity of calcaneum. We all are aware of it. It is responsible for plantar flexion. Guys, you remember dorsiflexion of foot. Who is responsible for dorsiflexion of foot? Tibialis anterior. Who is responsible for plantar flexion of foot? Tendoachilles. So sudden severe plantar flexion happened. Tendoachilles went into strong contraction, and that got avulsed from where? The posterior tuberosity of calcaneum. So this avulsion fracture of the posterior tuberosity of calcaneum is what is called as an avulsion fracture. You can very well see, how calcaneum has been avulsed because of this. This is one fracture pattern that I wanted you to understand, avulsion fracture. Now, apart from that, we have a depressed fracture. Depressed fracture can be seen in many bones. There are many patterns also, but I would like to categorically mention only one area, and I would like to show you only one example, and that is a depressed fracture of the skull. So guys, apart from incomplete, complete, closed and open, these are also two fracture patterns. These are two fracture variants, which are basically the avulsion fracture and the depressed fracture. But that's not all. You have two more fracture patterns here. One is called as the pathological fracture, and my dear friends, as the name suggests, as the name indicates, it is pretty clear to all of us that a pathological fracture will be sustained only if the bone is pathological, only if the bone is diseased. I'll give you an example. I'll show you an X-ray, but please try to understand any sort of disease in the bone. That can be tumor, that can be infection, that can be some metabolic disorder, that can be some localized issue, that can be some endocrinological issue, that can be anything. That can be any sort of a pathology. It can be systemic, it can be generalized, it can be localized, but the bone has to be pathological, the bone has to be diseased. And if you just give a trivial trauma to that bone, and if the bone gets fractured, that is what is called as pathological fracture. I'll give you a classical example. Now this 11-year-old child 11-year-old child never knew that he has any issue in his life. He was completely asymptomatic till the time. He was completely asymptomatic till the time he had a trivial fall. He was completely asymptomatic till the time he had a trivial fall. So he just had a trivial fall. Because of that trivial fall, he got up and he started crying, and he was taken to a doctor where this X-ray was done. And when they saw in this X-ray, they said, "Okay, fine, it's a fracture. Agreed, but there is something underlying that fracture, which is the actual reason behind that fracture." And it came out to be a case of a simple bone cyst. It came out to be a case of a solitary bone cyst or a unicameral bone cyst, and he was actually a patient of that. And now when we see retrospectively, everything makes sense, because proximal humerus metaphysis is the most common site for a simple bone cyst. And now I realize and I understand that he never had any symptoms because of this, because we all are aware of the fact that the most common complication, or in other words, the most common presentation at times of a simple bone cyst, the most common complication, or in other words, the most common presentation of a simple bone cyst is basically the pathological fracture. So this is something which is considered to be a very, very interesting aspect of the disease, that in a simple bone cyst you will never get to know that you have the pathology, you have the disease. It's just that after a trivial trauma or a trivial fall, you will land up into a fracture, and that is what is called as a pathological fracture pattern. Now, on the contrary, in pathological fracture, the disease was pathological, just a trivial trauma, the bone got fractured. Now, you have a normal skeleton, you have a normal bone, but the thing is that you're putting an abnormal, repetitive load time and again, time and again, time and again, time and again. And at one point of time, that skeleton says, "Boss, sorry, I'm not able to do this." You're like, "Okay, fine. You have fractured under a lot of stress, so you're a stress fracture. You got fatigued, so you're a fatigue fracture." Classical example, I'm sure you all have heard of it. Young guy, fresh young army recruit, wants to serve the country, and goes to a kind of a place where he wants to serve the country, and he goes for training. He goes to a defense academy every morning, evening, night for 5 kilometers. He is taken for a march past activity. 12th day, he calls his parents. He's like, "Dude, guys, come over and take me home, because on my normal skeleton or my normal bone, they are putting an abnormal repetitive load, and because of that abnormal repetitive load, there is this issue that because of the abnormal repetitive load, that the underlying bone goes into a stress fracture, it goes into a fatigue fracture. The underlying bone that goes into a fatigue fracture, that goes into a stress fracture, you can very well see. So this is basically called as march fracture. It is a pattern of stress fracture. All right, so it is the pattern of stress fracture, and I want you to remember that the most common bone involved is tibia. Most common bone involved in stress fracture is basically tibia. But what is march fracture? March fracture is stress fracture of neck of second metatarsal. And in other words, if I may summarize to all of you, that march fracture is technically the second most common site. It is the second most common site of stress fracture. So overall most common site for stress fracture is tibia, followed by second metatarsal, that to which part? Neck, and that is what is called as march fracture. So that is something that I want all of you to understand. So guys, if till now, if you see in the retrospect, if you see in the hindsight, so we had a classification, closed and open. We had a classification: incomplete, complete. Incomplete, we spoke about green stick. Complete, we spoke about what is transverse, what is spiral, what is comminuted, what is segmental, what is depressed. I gave you the X-rays, I gave you the fracture patterns, then we spoke about certain extra variants. Out of those extra variants, one thing that we talked about was avulsion fracture pattern, if you remember. We spoke about a compression fracture, a depressed fracture. Then we spoke about a trivial trauma giving rise to a diseased bone fracture, pathological fracture. Then a normal bone but abnormal repetitive load giving rise to a stress fracture, and a couple of MCQs related to that. So this is something that, I mean, this is one query that I get often from students from different parts of the country, that sir, in XY book or ABC lecture we have read or we have seen, we have not understood what do you mean by a shift, what do you mean by a tilt, what do you mean by a twist. See, it's very simple. There is a word called shift. Shift is nothing but translation, and tilt is nothing but angulation, and twist is nothing but rotation. I will give you an example. Alright, so just for everyone, just imagine that this is a bone. Alright, so this is a bone. Now the bone is actually fractured. So this is one proximal fragment, this is one distal fragment. Now if I actually shift the fragment like this towards you or towards me or towards this side, so that is what is called as a translation, that is what is called as a shift. But if I keep it here, but if I do it like that, this is called angulation, medial angulation, lateral angulation, anterior angulation, posterior angulation. If I take it away, medial shift, lateral shift, anterior shift, posterior shift. If I keep it here or if I keep it here, doesn't matter. Whether I tilt it or whether I shift it, doesn't matter. But at the end of the day, the distal fragment, understand, it goes into rotation. So that is basically the twist, that is the rotation. Are you able to understand this? Length is something that we all are aware of. So if you are actually moving the fragment, that is translation, shift. If you are just tilting the fragment, that is what is called as angulation. And if you are doing this, that is what is called as rotation. Are we able to understand this? So these are the different patterns of displacement that you should know. You should know what is the difference between a shift, a tilt, and a rotational twist. So I repeat again, this is shift, this is tilt, okay, and this is twist. Are we able to understand this? It is very important for all of you to understand. Guys, how do fractures present clinically? See, it doesn't matter how do they present clinically, it matters that how aware you are to identify a fracture or to distinguish a fracture. See, first thing is, the moment you see a fracture in the casualty, of course you have to take a brief history. How did this happen? When did this happen? Where did this happen? How will give you an insight that whether it is a crushing injury or a direct blow or a twisting trauma or an avulsion injury. When will give you an idea about the duration of the fracture, and that will help you to come to the consequences. And after where and after when and how, you have to talk about where. So when you talk about where, that also gives you an insight that whether there is injury that happened at home or there is injury outside the home, or whether there is any foul play for which you have to inform the police or not. The next thing is that you have to see the general and the particulars. Now when we talk about general and the particular, the first thing is always to see the age and sex. Age, what do I talk about age? Geriatric age group. I know geriatric people are more prone to develop a compression fracture in the spine due to osteoporosis. I know that geriatric people are going to develop pathological fracture, particularly of the neck of the femur and also the thoracic spine. I know the pediatric age group, you are going to have some sort of a physeal trauma, because in kids slip and fall from bike or from cycle or from some while playing something at home, it is quite common. So if you talk about the age, sex and history, that is definitely going to help you. But what is most important is that you have to first rule out an open fracture. You have to first rule out, as you can see here, you have to first rule out an open fracture, you have to first rule out a crushing injury, you have to first rule out all those things. Now after this, the next thing, if you can see, as I've already told you, that there is a neck of the femur fracture, quite common, seen due to osteoporosis. Colles fracture, quite commonly seen due to osteoporosis. Scaphoid fracture is commonly seen in you and me due to fallen outstretched hand. So there are different patterns. Like anybody talks about scaphoid fracture, my mind automatically goes into that mode that this is the most common fracture due to fall on outstretched hand in adults. So I know it is there in you and me. Do you understand my point? So it is there in young adults, it is there in you and me. Scaphoid fracture is for you and me whenever we have a fallen outstretched hand. Similarly, if I talk about Colles fracture, then this is also the most common fracture due to fall on outstretched hand. This is also the most common fracture due to fall on outstretched hand in elderly females. So, I mean, just take a look. It is so interesting and intriguing to know that a fall on an outstretched hand can lead to different fracture only if the age groups are different. If you are and me have a fall on outstretched hand, we'll have a scaphoid. If an old lady has it, she has a Colles fracture. So that is something important for us to understand. Now, coming to the next point, what are the typical clinical manifestations? Very simple. Anybody who sustains a fracture, the first thing is always, undoubtedly, is always the pain. The first thing is always actually most of the times pain realizes that yes, you have sustained a fracture. Then you see that, if you have a fracture in maybe one of the distal end of radius and ulna, you will be able to see that you are not able to do the wrist movement. Then of course you can see a deformity, there is a shortening, there is a cut crepitus, then of course swelling which keeps on increasing for first 2 to 3 days, along with discoloration if the bone which is fractured is quite subcutaneous. So these are the typical clinical features: pain, swelling, deformity, crepitus, bruises, loss of motion, all these things. Now, how do you diagnose? See, it's very simple. First thing is definitely the history. There's no doubt about it. Then you have to examine history. You have to see in history, it is very imperative for you to know that when did this happen, where did this happen, okay, when did this happen. The second thing you should know is where did this happen, and the third thing you should know is that how did this happen. All right, and then you have to see the age as well as the sex, because this also gives you a classical criteria, that gives you a classical idea. So history is important. Then in physical examination, we've already spoken about certain things, like for example, in every fracture you have to comment upon the distal neurological status. You should comment upon the distal vascular status. You should comment upon the fact that whether that fracture is a closed fracture or an open fracture. You should comment upon that as well. The next thing after that which comes here is basically the X-ray. We'll talk about that, and then CT, and then MRI. We'll talk about what is the significance of X-ray, CT and MRI. We'll talk about that individually. Now, whenever you have a fracture, guys, please try to understand. My boss used to say a line, which I'm going to say it for all of you, that, we were orthopedic residents. We were orthopedic residents, and in first year PG itself, we were orthopedic residents, and in first year PG itself, my professor told me that, guys, life first, limb later. So he said one very beautiful line, that life first, limb later. That life is the first priority, limb comes after that. Life means airway, life means breathing, life means circulation, life means cervical spine. I mean, if there is a patient of polytrauma struggling for life, he's having dyspnea, he's having tachypnea, he's having tachycardia, he's having hypoxemia, he's having hypoxia, he's in a state of some sort of a hypovolemic shock, he has probably developed some hemothorax, he has probably developed some pneumothorax, he has probably developed some flail chest, and I'm worried about a femur fracture. No. I have to take care of the femur fracture first. So that is what I'm trying to tell you, that life is a priority instead of limb. So your first job is to stabilize the patient. So that is basically what is the fundamental of ATLS, that you have to perform primary survey first. Primary survey means what? You have to assess the life-threatening injuries and you have to treat them. You have to see whether there is any cervical spine injury or not, whether there is any airway obstruction or not, whether there is any, foreign body occlusion, whether there is any broken tooth, whether there is any aspiration of the vomitus, whether there is any aspiration of the food content. You have to see any hemothorax is there or pneumothorax is there or flail chest is there, or all those things, and you have to manage them. You have to take care of the pulse, you have to take care of the blood pressure, you have to take care of the urine output, you have to see the hemodynamic status, and your priority is that. Once all those things are ruled out, then you start performing the secondary survey, and in that you talk about fracture. I mean, if you remember, ATLS clearly says that cervical spine is a priority, and after cervical spine, ATLS says that A, B, C, D, E. I vividly remember that we were taught that after C spine, airway is a priority, as I said initially, then breathing is a priority, then circulation is a priority, as I said, then disability evaluation. And when they talk about disability evaluation, technically they are talking about the neurological disability, and they are talking about Glasgow Coma Scale, if you remember. Then they used to talk about exposure of the patient, like completely undress the patient and dress the patient back again once you're done with the examination. And then they used to mention what? F stands for what? Fracture. Do you understand? F stands for what? F stands for fracture. So technically this F fracture is not there in ATLS. It is my lecture now, so I can have the liberty of introducing what I want to. So I've introduced F here. Technically F is not there. So fracture comes only after all those things. So even as an MBBS student, I want all of you to understand that fracture comes only after all these things. Now there is a fundamental here that I want you to understand as an MBBS student, that whenever you see a patient of trauma or a patient of polytrauma or a patient of fracture, then there is a dictum that goes like this, that look, feel and move. Now first thing that comes here is basically look. Now when I say look, that means you have to look for any swelling, you have to look for any bruises, you have to look for any deformity, you have to look whether the overlying skin is intact or not, you have to see the posture, and you have to see the color of the skin. So you have to just be a very good person for observation. So you will get 45 seconds and you have to just keep looking about swelling, bruises, any deformity, what about the overlying skin, what about the color of the skin, whether there is any tenting or not, ecchymosis or not, bruises or not. After look, as I told you, the next thing is feel. Now when I say feel, that technically means palpation. Look means inspection, feel means palpation. Now when I say palpation, very simple, you have to palpate for a localized tenderness. You have to palpate that area for a localized tenderness. The patient is complaining of pain, you press that area, the patient cries even more. That means it is tender. Then of course you have to see for the distal neurovascular status. As I've already told you, this is a final word from me to you today as an MBBS student. Whenever you see a fracture, it is not only that you come to the conclusion whether it is closed or open, whether that is incomplete or complete, whether there is any pain or not, whether it is tender or not, whether there is swelling or not, whether there is any deformity or not, whether there is any loss of range of movement or not. But the most important part that should never be missed is whether that fracture is associated with any distal neurovascular deficit or not. I've seen people getting failed in exam not commenting upon the distal neurovascular status. Very important. After look, after feel, the next thing is move. After look, after feel, the next thing is move. Now when I talk about move, it is the crepitus, you will see that. Abnormal mobility, you will see that. Okay, and now this is something which has to be done with extreme caution. You're not going to do this, and you're not going to do this in every patient that you're going to examine. So you have to be very careful, because your movement might hamper the adjacent neurovascular structure as well. So you have to be careful about that. As I said, my dear friends, we will talk about an X-ray. So now here we are talking about an X-ray. X-ray is the most basic investigation, I must say. X-ray is the most basic tool in my armamentarium, and any orthopedic surgeon, a visit to an orthopedic surgeon is not complete without getting an X-ray. Now when we ask for an X-ray, there is a rule of 2 that we follow. There is a rule of 2. I'll tell you what is this rule of 2, because this is very important for all of you. So we should have, first of all, we should have 2 views. I'm giving you the rule of 2s. It is a big rule. It is an important rule, interesting rule. Usually as in MBBS final year, MBBS Viva exams as well. So we use the rule of 2, in which the first thing is 2 views. Now when I say 2 views, what does that mean? That we have to have a AP view, we have to have a lateral view. Just one view is not going to help. Are you understanding my point? Just one view is not going to help. You can see on the left hand side of your screen right now, you have an AP view. I can't see any fracture. Just by getting one view, you may rule out a fracture. You can send the patient back home, but the moment you get a lateral view, you see a oblique fracture. So that is why what I want you to understand, it is the 2 X-rays, 2 films in 2 different views, where one is absolutely normal while the other one is showing a fracture. So you have to take care of the first rule, that is the rule of 2 views. After the rule of 2 views, are you understanding this? After the rule of 2 views, we have the rule of 2 limbs. Now what about 2 limbs? Pediatric skeleton. It's a big mystery. Why? In pediatric skeleton, most of the ossification centers have not appeared. Are we able to understand this? In pediatric skeleton, most of the ossification centers have not appeared, and that creates a very big problem. That poses a very big problem. Like for example, if I see this part, okay, if I see this part, if I see this part, now I'm pretty much confused that I'm dealing with what? I'm dealing with a fracture, I'm dealing with an ossification center. I don't know, because pediatric skeleton behaves in a very weird kind of a way, because you get confused. Okay, you get confused with all these ossification centers and all those things. Now if I look at this point, I get confused, but there is a very easy way to rule out the confusion. Get a contralateral limb X-ray as well. So I said, after the rule of two views, AP and lateral, I just don't want you to have two views of the same bone. I want you to compare those two views of the same bone to another two views of the contralateral same bone. So I got the X-ray of the other side also, and now I'm pretty clear in my head that I'm dealing with a fracture, and it is just not a mere ossification center. So in the rule of two, the first rule is rule of two views, and the next is the rule of two limbs. But that's not yet over. We have one more, a couple of more rule of twos, into which the first one that we have is two joints. The first one that we have is two joints. I'll give an example about two joints. This is something which usually an intern or a first year resident commits mistake in. The patient is complaining of pain and swelling in the forearm. The patient is complaining of pain and swelling in the forearm. The first year ortho resident or an MBBS student or an intern who was there prescribed an X-ray of the right forearm. Now the technician doesn't know. He's a technician. He's not a doctor, right? So the technician is not aware of it. He's fine. He says, okay, fine, I'll get an X-ray of the forearm. Now in this X-ray of the forearm, you can see some part of the wrist, but you are not able to see any part of the elbow. Now that guy the patient after trauma was complaining of pain in the forearm, and this X-ray was done. Elbow part was not seen. You are convinced because you can very well see that there is a fracture of the proximal 1/3 of the ulnar shaft. So you come to the conclusion, you inform your seniors that there's a fracture. I'm admitting the patient, fracture of the proximal 1/3 of the ulnar shaft. It has to be operated upon. Plating has to be done. I'm admitting that patient. And next day, the moment they land up into the OT or maybe somewhere else and they get an X-ray done, and in that X-ray they see that, I forgot, the resident forgot, the maybe student forgot the view including the elbow, and there is an anterior dislocation of the radial head, because this is a classical Monteggia fracture which involves fracture of the proximal 1/3 of the ulnar shaft along with anterior dislocation of the radial head. So that is why, my dear friends, I told you that it is not only the rule of two views, it is not only the rule of two limbs, it is also the rule of two joints, that whenever you're suspecting injury anywhere, please try to get an X-ray which should include one joint above and one joint below. Are we able to understand this? Not only you have to get an AP and lateral view, not only you have to get a right and a left limb AP lateral view, you have to include in that view that one joint above and one joint below should be covered in that X-ray. And not only this, you have to take care of the two injuries also. So after rule of two views, after rule of two bones, after rule of two joints, you have to talk about two injuries. Somebody has a calcaneal fracture. Okay. X-ray done. Okay. Calcaneal fracture. Okay. History, fall from height, rule out spine. Rule out pelvis. You have to get another X-ray to rule out injury to the pelvis or spine, because fall from height means that entire body weight is going down. Yes. You're landing onto the ground on your feet. Yes. Therefore you have a ground reaction force coming and fracturing your calcaneum. Yes. Then ground reaction force will definitely travel up. It'll go to the pelvis. It'll go to the spine. The person is lying down. He may not present it to you. You have to find it out. You are the doctor. It is your job. So you have to think. You have to think a lot. You have to keep thinking, because that is something with which you can develop your reflex, that not only AP and lateral, not only right and left, not only one joint above, one joint below. If I see an injury to the calcaneum, I will rule out pelvis and spine. And then we talk about two occasions. Now, when I say two occasions, I can show you something. I can show you something about two occasions. We saw a patient, he had a fallen outstretched hand, young chap, we got an X-ray. A young chap, 25-year-old, fallen outstretched hand from a bike, definitely we suspect fracture scaphoid. I get an X-ray done, I don't see any fracture scaphoid, never mind. I immobilize him, 7 days later, 1 week later, I get an X-ray done, I can very, very clearly see a fracture line here. So this is again very important. So this is what is called as two occasions. So what are the rule of two? So if I talk about rule of two, so it is not only the two views, it is not only the two limbs, it is not only the two joints, it is not only the two associated injuries, it is also the rule of two different occasions. Are we able to understand? So this is something pretty important about prescribing an X-ray and exact prescription as an MBBS student or a intern or a PG resident. Now, what about these special investigations? Three special investigations we will be discussing here. One is CT, one is MRI, one is bone scan. Now, when we talk about CT, please try to understand as far as CT is concerned. Uh, I'll be very honest in telling you that CT is important only for certain difficult areas, or only for certain inaccessible sites, out of which calcaneum is very important. Stabulum is very important. I mean, just on an X-ray, you cannot delineate the exact number of the fracture fragments and the exact anatomy of the fracture line on a X-ray. It is not possible, particularly if you're talking about calcaneum or you're talking about a stabulum. So there you have to go for a NC-CT, non-contrast CT, and there is a special thing that we orthopedic doctors we get done, that is with a 3D reconstruction, which give us a three-dimensional view, and we exactly plan our surgery accordingly. Then of course MRI has a very important role, particularly if you're trying to assess any spinal fracture, because in any spinal fracture, because of the retropulsion of the fragment into the cord, there is quite a possibility of the involvement of the cord, which we can rule out only after getting an MRI, So that is something which is again important. Now, stress fracture, I'll be very honest in telling all of you that at one point of time, yes, stress fracture was considered to be seen best on a bone scan, not now. In fact, I would like to conclude here the investigation part. I would like to conclude here with this MCQ, that investigation of choice for stress fracture, if it is a unilateral stress fracture, we talk about MRI. If it is a bilateral stress fracture, then definitely it is bone scan. If it is unilateral, it is MRI. If it is bilateral, it is bone scan. So this is the fundamental that I want all of you to understand. So guys, if you see till now what we have understood is, what is a fracture, what is the classification, what is incomplete, complete, what is closed and open, what are the different pattern, what are the different variant, how does it present clinically, what all investigations to be done, CT for an accessible area like calcaneum pelvis, particularly with 3D reconstruction, MRI is to see spinal fracture involving cord. X-rays are important, and I have already told you that it is the most basic mandatory investigation where rule of 2 is very important. Now, there is a line which I have written here, is of course something that is the gist of my first year post graduation. After first year PG, I was taught this, that diagnosing a fracture is not enough. Not only enough, it is not required. What is required is that how you approach that. Like, the first thing is always it's always a priority. The moment you see a fracture, you have to look for the presence of the overlying skin and soft tissue, whether it is open or closed. Then if it is closed, then which bone is this, whether it is tibia or whether it is femur or radius, and if it is a tibia, then which part of the tibia, proximal tibia, shaft of tibia, distal tibia. Now, whether it is proximal tibia or distal tibia, I have to see whether there is involvement of any joint surface or not. Why? Because involvement of a joint surface will make it intra-articular, and intra-articular fractures have their own issues. What is the biggest issue with an intra-articular fracture? That these intra-articular fractures have a tendency to go into non-union. These intra-articular fractures have a tendency to go into non-union. Why? See, understand, intra-articular fracture means that fracture extending into what joint? What is there inside the joint? I'm asking you all a question. What is there inside the joint? Synovial fluid. So there is a synovial fluid. There is a synovial fluid in the joint, and synovial fluid in the joint has a property of inhibiting the fracture healing. Synovial fluid has a property of inhibiting it has a anti-healing properties. So that is one big problem, and that is why I would want you to understand that every intra-articular fracture needs open reduction. It needs open reduction and internal fixation. It has to be operated upon. You just cannot leave a intra-articular fracture with closed treatment. Now, so you have seen whether it is open or closed, which bone is broken and whether there is involvement of any joint surface or not, and then what is the shape of the break. Now, when I say shape of the break, what does that mean? That simply means that whether fracture is transverse. Just hold on, guys. That simply means that you have to ascertain. That simply means sorry, the OneNote got crashed. So that simply means you have to ascertain whether the fracture is transverse, or whether the fracture is transverse, or the fracture is oblique, or the fracture is spiral. Now, I want all of you to understand this as well, that this is a transverse fracture, this is a oblique fracture, this is a spiral fracture. I want all of you to remember that spiral heals earlier and better than oblique, oblique heals earlier and better than transverse. Why? Because of a simple logic, that rate of fracture healing is directly proportional to surface area between the fracture fragments. So rate of fracture healing is directly proportional to the surface area between the fracture fragments. Now, once you have seen all these aspects, then you have to see, all right, so then you have to see whether the fracture is stable or unstable, whether it's a high energy or low energy injury. Every fracture is a different personality in itself, and that is the fundamental that you have to come to the conclusion. So I repeat, the moment you see a fracture closed or open, if it is closed, you have to see which bone is broken and where, then whether it is involving the joint surface on an X-ray or not, what is the pattern on an X-ray, whether it is stable or unstable, whether there is a shift, there is a tilt, there is a rotation, there is a high energy trauma, there is a low energy trauma, what is the status of the distal neurological and vascular condition, and then you are good to go for a higher investigation if needed. So guys, this was the utmost basic aspect of a fracture. We discussed fracture under certain headings, which are etiology, which is definition, which is etiology, which is the types, which is the pathogenesis, the clinical picture, the investigations, and of course the diagnosis based upon the investigations. We have to talk about the management. Management is altogether a separate ball game, where we will discuss what is reduction, what is closed, what is open, what is the role of a splint, what is the role of a traction, what is the role of a slab, what is the role of a cast and internal fixation, how nails and plates are used, external fixation, how external fixator is used. We'll talk about all those aspects of management of a fracture in a separate video. The purpose of this video was to give you a basic understanding of this word called fracture, because for most of the students in MBBS or in pre-final year, the word orthopedics is nothing but synonymous to fracture, although orthopedics has to deal with many other things apart from fracture. So guys, I hope you liked the video, you got some information, you got some basic concepts, and of course we covered a couple of MCQs. As you must have noticed, at certain points I told you about certain important one-liners. We will be coming up with this next video on management of a fracture very soon, where we'll be discussing the emergency management, the elective management, and not only that, we'll be talking about the fracture healing and the variables affecting fracture healing. So stay tuned to the YouTube channel, and looking forward to see you guys again. Thank you so much. Bye bye. God bless.